This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may be undertaken with prior written consent of the AARC. Copyright 2012, all rights reserved. My name is Bill Dubbs. I am the AARC Director of Education and Management Services. I welcome you to today's webcast on Hospital to Home, Efforts at Reducing Hospital Readmissions. At the completion of our webcast, you should be able to clarify the current challenges of readmissions for cardiopulmonary conditions. Describe the strategies of federal payers to encourage reductions in admissions. Describe the methods, metrics, and outcomes achieved by the hospital-based successful readmission reduction program at Sanford Medical Center in Fargo, North Dakota. And finally, describe the methods, metrics, and outcomes achieved by the home care-based successful readmission reduction program at Klingensmith Healthcare in Ford City, Pennsylvania. I am pleased to introduce Greg Spratt. Greg is a registered respiratory therapist who is currently employed as Director of Clinical Marketing for Covidien Orion Capnography. Greg is also chair of the AARC Home Care section. He has been involved in hospital, rehab, and home respiratory care for over 30 years. Also joining us today is Becky Anderson. Becky is also a registered respiratory therapist, currently employed as a disease manager in respiratory care services at the largest rural health care system in the nation, Sanford Medical Center in Fargo, North Dakota. Also presenting is Kimberly S. Wiles. Kimberly is also a registered respiratory therapist, currently employed as Vice President for Respiratory Care at Klingensmith Healthcare, a home care company located in Ford City, Pennsylvania. All of our speakers disclose no conflicts of interest related to this presentation. Brand names of products may be mentioned only as examples of technology. Greg, welcome to the program.
Well, thank you, Bill, and good morning, good afternoon to all of you today. Thoughts are with those of you that are Bill, I'm not able to advance my. Oh, there it goes. Okay. What I'd like to do is provide a little background information for Becky and for Kim's talks today, and talk a little bit about some of the statistics that are available on hospital readmission rates, and also some of the initiatives that are underway by the government. When we look at hospital readmission rates, and this is data from Jenks from just a few years ago in the New England Journal of Medicine, almost 1/5 of our Medicare beneficiaries who had been discharged from the hospital were then rehospitalized within 30 days. So one out of every 5 patients. Over 1/3 of those were rehospitalized in a 90-day period. And the statistics, when you look at them specifically for COPD, are actually a little bit higher than the averages, with almost a 23% readmission rate within 30 days. A reality of our reimbursement system in the past has been that, to a large extent, hospitals have been somewhat financially incentivized to readmit patients. In fact, if you look at average hospital's revenue, you'll see that a significant percentage of revenue in the past has been due to readmissions. When we look at some of the government data on the potential savings from reducing readmissions, it's a significant number. MedPAC published some data that was back in 2005 showing that Medicare expenditures for potentially preventable rehospitalizations may be as high as $12 billion a year, and that's 2005 dollars, so even higher today. To respond to this, the government included in the Healthcare Reform Act some changes to the system to try to incent hospitals to look at these readmissions and see what they can do to reimburse them. The Patient Protection and Affordable Care Act that was signed into law back in 2010 included modified Medicare payment rules for hospitals. We don't have time to go into all the details of those today, but if you read through that huge document, which we have a link on the slide here, you'll see that they've established a number of new programs, some demonstration projects, pilots, designed to reduce readmission amongst other purposes. And they've actually slotted significant funding for this to occur, at least $500 million in funding over the next 5 years, and that amount can be expanded. Part of the Act is the Hospital Readmission Reductions Program, where there's actually now financial incentives for hospitals to lower readmission rates and disincentives to have high readmission rates. And we're just going to touch on these again today. For discharges that are starting after October 1st, 2012, which you all recognize is coming up here in a little over a month, hospitals must establish programs for preventable readmissions for 3 of the highest volume and highest rate conditions, and I'll get to those in just a minute. This will be expanded by at least 4 conditions in fiscal year 2015. It could be more at their discretion. And hospitals with excess readmissions will have all payments, not just for these readmissions, but will have all of their hospital payments, Medicare payments, reduced by an adjustment factor based upon a kind of a growing scale over the next 3 years. The 3 diagnoses that they're looking at initially for readmissions that will be impacted in fiscal year 2013, again that starts in October of this year, are heart attack, heart failure, and pneumonia. And then beginning in fiscal year 2015, that list will expand to include other conditions, one of which is chronic obstructive pulmonary disorder. So you can see that certainly the diagnoses that are impacted by this, both this year and in the future, are ones that we as respiratory therapists work with on a regular basis. To respond to these changes, the AARC has created something we call the Hospital to Home Initiative. And this was based on a directive that came from the AARC Board of Directors and the executive team to look for opportunities for RTs to begin to be involved in programs to reduce readmissions. We started this effort back in 2010, just before the Congress meeting, and since then we've been having regular meetings and discussions about this in joint sessions of both the home care section and also the management sections. I've been working with Bill Cohagen in that regard. We've had several things that have occurred since the initiation of this project. We actually did a survey of the AARC membership on readmissions. We had multiple sessions at the 2011 and also planned for 2012 on the Hospital to Home Initiative. We are currently funding, the AARC is funding a study on reducing readmissions. It's just getting underway. And then we're also exploring the potential support of other pilot studies like those you're going to hear about today. And with that, I want to get to the real meat of this. I wanted to set a background for Becky and Kim, and I'm going to turn it over to Becky.
Thank you, Greg. Hello, everyone. Today I will be sharing our systems change project to standardize inpatient COPD care and reduce readmissions here at Sanford Medical Center in Fargo. This process really began for us in 2007 when several initiatives emerged to form a very strong climate of support to begin transformation of COPD care. Our organization's 5-year plan included strategies for chronic disease management, using evidence-based guidelines, of which more than 30 had been published since 1992, and also by utilizing clinical practice standards. In addition, our administrators were performing DRG analyses to find areas where we could improve financial outcomes. The students in our respiratory therapy bachelor's degree program were trying to identify a senior research project, and Gary Brown, the director of respiratory care services, had been mulling over a study on the quality of inpatient COPD care, which had been published the previous year in ACP's Annals of Internal Medicine. So it appeared that the stars were pretty aligned for us for this systems change project. You can see the results of our DRG analysis for fiscal year 2007 for COPD, DRGs 190, 191, and 192. At that time, we had an average net loss of $615 per admission. Charges and costs for this group of patients was increasing, and unfortunately, reimbursement was decreasing. Our length of stay was rising. Ideal care occurred only 34% of the time, and keep this ideal care notion in the back of your mind. We'll discuss that further in just a minute here. We had no clinical pathways or standing order sets. The physicians managed these hospitalizations based on their education, experience, and backgrounds, and handoffs between the providers really appeared to be an issue. Also, respiratory therapy orders generally consisted of the patient's home inhaled medications, and although we have been working under a protocol system in our department since the 1980s, we did not have a disease-specific inhaled medication protocol for COPD. And all-cause 30-day readmissions was quite high at 20%. This is from 2008, right before we started our program. With the DRG analysis in hand, our next step was to measure the quality of inpatient COPD care at Sanford Medical Center. And to accomplish this project, our senior students replicated the research study that I mentioned on the previous slide. In that study, Dr. Peter Lindenauer and his associates conducted a retrospective cohort study by utilizing a database that was developed for measuring quality and healthcare utilization, which pulled in hospital charges for more than 69,000 patients who had been admitted for acute exacerbation of COPD to any of the 360 participating hospitals. They identified recommended and non-recommended care from charges, and they compared the results to guidelines from the ACP and ACCP. What they found was that 68% of patients received recommended care, 44% of patients received at least one of the non-beneficial measures, and in all, only 33% of patients received ideal care, which they identified and defined as having received all of the recommended cares and none of the non-recommended cares. In replicating the Lindenauer study, our students reviewed the charges of 244 patients hospitalized during the previous 18 months who had a diagnosis code of COPD. When compared to the results of the national study, you can see that the results were similar, with only 1/3 of patients receiving ideal care. So the results confirmed that we were average. And we do not aspire to be average, so we knew that we could do better. Based on the DRG analysis and the quality of care study, our administration appointed Gary Brown, Respiratory Therapy Director, as the project champion for development of a plan to improve care and reduce cost for COPD inpatients. Gary then pulled together a multidisciplinary work group from across the system to develop a standardized process for treating exacerbation of COPD. That group developed specific goals and objectives for COPD disease management, including several key tools to be used by patient care providers in the hospital. One of the key components of our program is the COPD admission order set, which utilizes the recommended cares identified in the Lindenauer study, as well as guideline recommendations from other sources, including GOLD guidelines from NHLBI and the World Health Organization. Recommended cares includes oxygen therapy, chest x-ray, the use of bronchodilators, steroids and antibiotics, And in this patient population, oral steroids and antibiotics are as effective as IV, and the cost of oral is 1/10 the cost of IV. So our orders reflect this preference. However, we do know that some patients will require higher doses of steroids, which may need to be administered by IV, and the physicians always have the option of choosing either route. Respiratory therapy also developed a non-invasive protocol, non-invasive ventilation protocol, and an as-needed order for that is included in this admission order set. Our goal throughout this process is to be very aggressive in bringing the exacerbation under control. And it is vital that non-invasive ventilation, if needed, is started early as possible, as it reduces the need for intubation by 65%. We know that intubation in this patient population is related to increased mortality, so we have to be very aggressive in preventing intubation whenever possible. And of course, we also included vaccinations, a very important component of care for this patient population. And then there is the consult section. We wanted to make sure that we included respiratory therapy protocols, and there is an order for the RT COPD clinic specialist, which is a position, a brand new position for our organization that was created to provide care coordination and discharge planning throughout the hospital stay, and also to provide patient education before discharge. Of course, tobacco education as needed. This is provided if the patient has used tobacco in the last 12 months, not only for this patient population, but for all of our patients. Pulmonary rehab, a very important component to reducing hospitalizations and increasing quality of life for our COPD patients. And we include a nutrition consult as needed. We know that this patient population is at high risk for poor nutrition, especially when they go home post-hospitalization with a lower energy level, sometimes difficult for them to shop for food, to prepare food. Cachexia in this patient population is a very real problem, and of course cachexia is also an indicator of high mortality. And then we have orders for case management. There, I would say 100% of the time, this patient population is case management follows through and works with the COPD specialist in identifying needs for discharge, and then other therapy services, PT, OT, speech as needed. The other key tool that was developed by the work group is the respiratory therapy COPD medications protocol utilized by our staff therapists. Again, our goal is to be very aggressive in bringing exacerbation under control. So when the patient is admitted, we start with nebulized short-acting bronchodilators, and by utilizing a score based on patient symptoms, move to long-acting bronchodilators when appropriate. By reducing the professional time of the respiratory therapist through the use of long-acting bronchodilators, we've been able to reduce cost and also increase patient satisfaction. When I first started this position, I thought that these COPD patients were going to rebel when we took them off their home medications and started a protocol in the hospital. I found quite the opposite, and part of the buy-in from the patients came obviously from explaining what we were trying to accomplish in the hospital, and that their home medications weren't working at home at the moment, and so we needed to be aggressive in starting on another protocol to bring this exacerbation under control. However, even though we moved to the long-acting bronchodilators and only treat the patient twice a day in general, the protocol also stipulates that the therapist will continue to assess the patient every 4 hours until discharge in order to prevent any backward slide in the respiratory status. And the therapists are able to use the protocol to switch back to short-acting bronchodilators and increase frequency as needed. Patient education is also a key component to reducing readmissions, and while the hospital is not always the best teaching environment, we want to make sure that the patient has a good understanding of how they can manage their disease to reduce the likelihood of hospitalization. And so we have this brand new position of clinical specialist, and they provide education partially based on patient need. At the very least, they review the basics of COPD disease process and go over the patient's home inhaled medications, which are not necessarily the same medications as they receive in the hospital. They utilize the teach-back method, making sure that the patient really understands how to take their medications, and if they are taking a medication that requires spacer use, we give them a spacer to take home. Also, our tobacco cessation educators are part of the respiratory therapy department, and as I said, the patient receives an automatic consult if they've used tobacco in the last 12 months. And other topics as identified, the clinical specialists spend a lot of time discussing with the patient what brought them in, really getting down to the nuts and bolts of what brought them in, what was going on in their home life, what was going on that brought them back to us. And they supply them with educational material in a take-home folder that they also review some of the information in there. Other topics that they might review with the patient include infection control, airway clearance, pursed lip breathing, work simplification, some of those key components of education for COPD patients. Another process that the respiratory therapy clinical specialist takes part in is discharge planning, which is arguably the most important component in reducing readmissions. Comprehensive discharge planning is a function for which our clinical specialists are uniquely qualified. They understand this patient population, they understand their inpatient needs, their outpatient needs, they understand some of the difficulties that these patients experience in trying to access the system, and they work really as navigators to help the patient get in line with some of the ambulatory and outpatient services that might be needed. Again, the specialists collaborate with case management. They don't take the place of case management. Case management's main concern is discharge disposition, and so the clinical specialists work close with the case managers to make sure everything's in place at discharge. The clinical specialists work closely with the patients, the patient support system, the nurses, and the physicians to identify and resolve barriers to successful transitions. And we have built templates in our electronic medical record that allow the clinical specialist to send the discharge recommendations through the EMR directly to the hospitalists, so that the hospitalists, when they're writing the discharge orders, have the information about what was decided for the discharge plan. And of course, again, pulmonary rehab referral. Every patient who is able to participate in pulmonary rehab is just discharged with this order. Pulmonary rehab reduces hospitalization, it reduces ED use, and it increases quality of life. Extremely important component of outpatient COPD care. One thing that we're not very good on here in the Midwest is talking about the end of life. And so this is a very important component. Generally, should probably not be addressed in the hospital, but if it hasn't been addressed, this might be the place that we start the discussion. Advanced care planning, end-of-life planning really should begin earlier in the disease process, not when the patient's breathing on their last alveoli. This needs to be a process that they are discussing and making decisions upon when they're feeling relatively well and when they're not right at the end of their life. So lots of room for improvement in that area. And then we also partner with the ambulatory and outpatient healthcare teams to share the health management plan and make sure that everybody, including the patient and their family support system, is on the same page. We also do post-discharge follow-up, and in the past, we have followed up mostly through the patient's EMR, making sure that we're communicating with the primary care providers if we have any concerns that they should be notified, monitoring the post-hospital appointments. Did the patient make it to their appointments, and what were the results of those appointments? We have recently started telephone contact directly with the patient at 1 week post-discharge and then monthly for 1 year. This the start of this project is based on a study by Dr. Catherine Rice and colleagues at the Minneapolis VA, which found that direct contact with the patient post-hospitalization significantly reduced readmission. And this is a chance for our clinical specialists to discuss the plan that they and the patient and the care providers decided upon when the patient was discharged. Were they able to pick up their medications? Do they have any questions about their medications? And just in general, how things are going. The idea is not that they stave off admissions that are actually needed. They need to encourage the patient that if the patient is having difficulties and the exacerbation is not resolving, that they need to get back into their primary care provider, the walk-in clinic, or the ED, and be very attentive about getting help in those situations. And we are also looking at setting up a telephone and email helpline for the patients in the future so that we can answer some basic questions about COPD self-management. And so let's take a look at our outpatients for our inpatient care program. The students had done audits the first year that compared us to the national averages for recommended care, non-recommended care, and ideal care. And that first year, we were average. 1 year after we started, we had improved recommended care to 71%. The next year, we were up to 86%, meaning that patients received all of the recommended care measures. Non-recommended care, we were able to reduce slightly. And our ideal care after the first year increased significantly to 49%. We have gone back and are tabulating our non-recommended care and ideal care for 2010 and 2011, and if you are at AARC International Congress in November, Gary will be talking and sharing some of our more updated outcomes at that time. Look at our financial outcomes. This was one of the big components, the big things we were looking at first is that in general, medical DRGs lose hospital money. By being able to take a look at how we deliver care and when we deliver care, we were able to have very significant improvement in our financial net margin, which was not our only consideration. However, you can see that it can be done. We were able to hold down the cost of care to allow reimbursement to rise, and therefore we have turned around a negative net margin into a positive net margin. Our readmission data. We've always been pretty good at readmissions for the same MS-DRGs. So when our patients are admitted for COPD, go home, and come back for COPD exacerbation, each of these points is one patient, perhaps 2 or 3 patients here. So we've been quite good at readmissions for the same MS-DRG. And when we take a look at readmissions for any reason, you can see we started right as we were starting. We were at 33% for this patient population. We had a nice steady decline throughout our first 2 years. And our last slide will show you why it's very important to stay on top of your outcomes throughout the process. This is same readmissions for any MS-DRG looking at the end of 2010 and through 2011, and you can see that we experienced an upward swing in our readmissions, which points out several key considerations concerning outcomes. The first consideration is that outcomes should be continuously monitored to identify improvement opportunities. And secondly, it's really important to understand what your outcomes are telling you. In this case, across this portion, we had 2 patient outliers who made up the bulk of these readmissions. We had already identified them as high risk for readmission, and we were working on processes to reduce that. But in this time frame, one patient had 31 ER visits and 12 hospitalizations. So you really need to know what your information is telling you and how you can use that information to improve your outcomes. To summarize, reducing readmissions for inpatient COPD care, it's important to use clinical pathways and RT protocols to aggressively treat exacerbation, get it under control, which will have an impact not only on your length of stay, but also your mortality rate and your patient satisfaction. Employ use of respiratory therapy clinical specialists. Respiratory therapists have a very good understanding of this disease process and what the needs are for both inpatient and outpatient care. And they can really facilitate the transition process, a unique role for respiratory therapists in the hospital. Provide pre-discharge patient education, very important that they understand their disease process and how they can manage their disease to live well at home with their disease. We need to identify and resolve transition barriers with the patient. Let the patient tell their story. You really need to get down to the nitty-gritty of what's bringing them in. We know they're in for exacerbation, but why did that exacerbation occur? Also, we need to partner with ambulatory and outpatient healthcare team. Hospitals cannot do this on our own. We need to make sure that we are all on the same page, that patients are able to transition seamlessly throughout our systems. Post-discharge follow-up has been identified as reducing readmissions, and we need to continuously monitor our outcomes for improvement opportunities. And with that, I will turn this over to Kim Wiles from Kling & Smith Healthcare, who will share their very successful home care program.
Thank you, Becky. That's probably a great transition at this point because, one of the things your program has shown is it's a wonderful program, but you got to make sure that that patient is handed off to the right caretaker, and that's where we come in the home. Our program actually started about 3 years ago, and we were a DME company located in Western Pennsylvania. And really, we were in one of the first competitive bid areas and saw that they weren't really paying for service. We were providing a lot of service, but the equipment part of it was starting to become a commodity. So we had to bring value to what we did and gather those outcomes. And that's when we started it's called DASH, Discharge Plus Assessment and Summary at Home. And basically it was a program that created new partnerships for the effective transition of care and beyond. So with that, let me just advance here to the next slide. So what is DASH? Well, it is a home respiratory care program. It started out as just a respiratory therapist-driven program and has evolved into a full, what we like to call ourselves as a hybrid DME, HHA, or home health agency. Since we've evolved to this end, we really believe that this program begins with an enhanced discharge. And Becky's program is ideal for that. She talked about a clinical specialist starting the program prior to discharge. We fully believe in that as well. So if our hospitals do not have that position, which in Western Pennsylvania we're not seeing that a lot yet, so we're providing that enhanced discharge. And what we're doing is actually going in when we get the referral for the oxygen patient, or actually it's in a lot of the order sets now that just says DASH, and we go in and we risk manage them. So we have a tool that we put them into what we consider low risk, high risk, moderate risk. And if they're high risk, we deploy all of our resources, and if they're low, it may be a little bit less. But what we've done in Western Pennsylvania is we've actually reduced the 30-day readmissions rates to less than 4%. In Western Pennsylvania right now it's about 28%, and we've reduced that to 4%. We've improved patient performance, and one of the key components of our program is really to develop self-management skills. And I know Becky had mentioned that as well. But once they get into the home, as we all know, it is a completely uncontrolled environment. And what one patient's environment may not be a problem, but the other one may hinder them. And they learn these are a lot of new problems once they come out from a readmission. So we really have to look at how do we develop these management skills, and it is really a patient-by-patient skill. We want to achieve medication best practices, and I'll go through that a little bit further as we go through the slides. But really what we did is we developed a novel respiratory software. We developed protocols to go with that. And the most important part of the program is to be able to have key metrics in reporting. And I'll go through that a little bit further as well. So really the DASH begins prior to discharge, and with a transitional coordinator, which is either provided by the hospital, which unfortunately in our area, as I said, that's not always a given. So we provide that patient, and we go in and actually do a risk evaluation. And when you look at these three areas here, I have risk evaluation and I have assessment, and I'm just going to get my little pointer here, bear with me. So we have risk evaluation here, and if you have 5 minutes to work with a patient, this is great. You can go in and figure out very quickly what level of risk they are. What is the respiratory diagnosis? How many major comorbidities do they have? Have they had an acute exacerbation within 6 months? Have they had a length of stay greater than 5 days? Were they on a vent? Were they in ICU? All of those determine at what risk level these patients fall. So if you have that key information, you can decide at what protocol you put them into once they get into the home. An assessment. I know a lot of this is not done in the hospitals. What we're seeing here, most of our patients are not even coming out with spirometry. So if we can get those done in the hospital, that's great, but a lot of times they don't want to do it in the acute setting, so they wait till they come home, and we'll do a screening within the home. We look at shortness of breath. We look at ADLs. How many activities of daily living can they do? If they can do less than 2, data shows you that it puts them at risk for a readmission. We look at what their saturations are. I'll probably get into this a little bit more later, but unfortunately, when patients come into the home, oxygen therapy is completely different, and each device delivers something different at a setting. So the setting that we get is just a guide. So we have to make sure that we're accurately matching up the device to the patient and keeping their saturation at good levels throughout the whole ADL process. We look at breathing skill sets and self-management. Standing, can they stand? Do they have risk of falls? What medications are they on? Are they on antibiotics, steroids? What is their cognitive status? And we can get a lot of this very quickly within the hospital setting as well. We may not be able to get the spirometry and the ADL activity, some of those things, but we can look at cognitive status, we can look at vaccinations. Do they have a problem with secretion management? And then we want to transition into the home. So this is prior to discharge, but we want to introduce them to what the DASH program is. We want to set expectations up front. This is what to expect when you go home. We would like to have them screened internally for OSA because we know that can be a comorbidity for a lot of these disease states, especially your congestive heart failure patients. We also start right within the hospital of asking the patient to set a motivational goal. What do you want to be able to do within 30 days? And it's something achievable, and it's something personal to them. For example, I want to go to the grocery store, or I want to go to the movie with my grandson. We want to set that goal, and then everybody that's involved in that care of that patient in the whole continuum knows what that motivational goal is and work towards that. That gives them that feeling of independence. We want to see what their dyspnea and anxiety levels are. Again, what is their medication? Do they understand it? Is there a pulmonary visit or a PCP visit scheduled prior to them leaving the hospital? So this is just a scorecard that we give them, and I know it's a little difficult to read, but basically all it is it's just a start. Do you have an understanding about what the DASH program is? Do you know how your COPD affects you? Do you understand the medications? Do you understand how to use a spacer? Do you know what to do in case of a flare-up? And you're really bringing it down to their level, because if you ask a patient if they've had an exacerbation or if they know what to do in an exacerbation, they're probably going to look at you like you have 4 eyes. So you want to ask them and explain to them what a flare-up is, or a lung attack, or whatever you want to call it, but use it as a standard terminology within your company. So then we actually send this scorecard with them, and we also have a take-home folder that we give them with some of the information inside it prior to us getting into their home. And then, they get an understanding, and then that starts to help them build confidence. And we use this scorecard throughout their admission with us. And we look at different things that are building their independence towards their goals. So, whenever you're looking at a COPD, CHF pneumonia program at home, it really requires specialization because, again, once you get into the home, you're in a completely uncontrolled environment. So respiratory skill sets really equal to self-management. Again, we want them to establish a goal. Do they have a physician follow-up appointment? And some of our early data that we were gathering, we were finding that less than 10% of the patients were coming home with a follow-up appointment to the physician. We increased that number to 90% because we actually had the respiratory therapist call from the home and schedule their appointment. We educate them on the disease. We don't educate them in extreme detail on how the disease has progressed and what is involved in COPD or CHF. That is on a basic level. What we really want to do is understand we want them to understand how to live with it. What kind of action plan can we give them to understand with their disease? We do breathing skill sets and really do an introduction to pulmonary rehab because, as Becky said, this is the #1 thing that you can get patients involved in to get them into a pulmonary rehab facility. So we really want to work with the breathing skill sets. It's amazing how many patients just don't understand that it's basic in through the nose, out through the mouth, and when in doubt, exhale, because a lot of these patients tend to hold their breath, as we well know. And what is exacerbation control? What should they do to control their exacerbation or flare-up? Oxygen saturation is very key within our company, and that's really how our program started, was around our oxygen therapy program. But it is just absolute key to make sure these patients are saturating at all levels of activity. In the past, we would do a 6-minute walk in their home, which really made no sense because how many patients walk around their home for 6 minutes? So we actually incorporated ADL titration. So we have the patient maximum pick 4 ADLs. It could be anything from bathroom simulation, shower simulation, meal preparation simulation. Running the sweeper is a big one because a lot of patients can't do that anymore. So what we do now is we actually titrate their oxygen while they're doing the ADL titrations, as well as work at the breathing skill sets, in through the nose, out through the mouth, pursed lip breathing, very key in a lot of these activities. Dyspnea is a big one. We get them to understand how to control that dyspnea. We look at Borg scores on a daily basis, whether it be the respiratory therapist, the physical therapist, the occupational therapist, or the nurse. That is key. Heart rate recovery we look at as well, because if the patient can't recover after doing these ADLs within 3 minutes, we know it puts them into a different risk category. What's their BMI? We look at secretions, vaccination, risk of falls, a lot of this information, as well as spirometry. Again, our initial data come back showing us that less than 20% of our patients enrolled in the program had spirometry. So we now do baseline spirometry when we get into the home, and we stage them according to the GOLD guidelines. We've also expanded our care, as I had said, that looking at comorbidities, because we know we're respiratory therapists and we can take care of the respiratory patient, but unfortunately a lot of these patients have comorbidities that are beyond our realm. So that's when we started our home care agency that now allows us to expand that into nursing care for homebound patients, occupational and physical therapy visits to support that independence and really start that pulmonary rehab teaching and training in the home so that we can actually discharge them into a pulmonary rehab from the home health side. As behavioral health, a lot of issues come into play with COPD patients with behavioral health and smoking, as we all know, and this gives us the opportunity to bring that in, as well as nutritionists, social services, and we look at telemonitoring as well. So what we did is we actually created our own software within a small access database that has really grown into more of a point-of-care system. But when you look at the point-of-care systems out there for respiratory care, they're very poor. And if you look at the point-of-care systems for the home health agencies and the nursings, there's a standard question set that must be completed by a home health nurse in the home, and that is called the OASIS. It is about 100 questions, and it has questions regarding risk of fall, depressions, history, a lot of information, but out of that 100 questions, there's only 2 that are specific to respiratory, which is a real shortfall in my eyes when you're trying to evaluate the risk and the ongoing needs of a respiratory patient. So we come up with a lot of our own questions by digging up a lot of research and best practices. From that software comes a dash summary form that is a one-page report of the most important things within that software, and that goes to the physician. And from that, we also gather outcomes, and this is a report that we can pull by hospital to show them all of the patients that come out of that hospital, what the metrics were that we measured, and how we worked with them. So this is just a little clip of that software. So it translates measures into metrics, and we look at pretty much everything that we do. We look at, can they achieve their motivational goal? Had they achieved it within 30 days? How many of those patients had physician follow-up within 14 days or 30 days of discharge? Were they on the key medications, and were they adhering to those medications? How many of those patients went into pulmonary rehab? And this was a really interesting find when we first grabbed our data from one of our major hospitals, is they have a wonderful pulmonary rehab facility. Unfortunately, of the 25 patients that come out of that hospital in that month, only 1 was prescribed pulmonary rehab. So it was a real eye-opener when we went back and sat down with the upper management and said, okay, only 1 of your patients was ordered pulmonary rehab. Well, since then, they've put some protocols into place. Pretty much what Becky said is they're ordered that prior to discharge now. We looked at heart rate recovery, we looked at Borg scores, and we found that a lot of our readmissions definitely showed a Borg score greater than 3, and they weren't able to complete 4 ADLs. So a lot of these measurements really lead to new tools, and it helps you to develop your program. So you really need to get a list of what you want to measure, and if there are outliers, you need action plans to support that. So this was our first stab at our 229 patients. This is a little bit of old data. We do have some newer data, but unfortunately we're having a little complication with pulling that right now. So I took our old data, but it was pretty compelling. 45% of the patients we found were not able to complete their 4 ADLs. We did have 4 COPD readmissions on that. So what that tells us is we really need to get more PT and OT involved and really get protocol in there to increase their strength and endurance. We also, 42% of them reported a Borg score greater than or equal to 3 on the ADL activity. We had 6 COPD readmits there. This was really interesting to us, but 29% of them failed to be prescribed the proper medications. We had some patients coming into our service without even a short-acting bronchodilator, which was really scary. Only 12% of the total population had entered pulmonary rehab. 100% of the COPD readmits that we had out of these 229 patients had a BMI of less than 22, which allowed us to implement a nutrition program or consult. And this was interesting to us as well. only 31% had a home health agency. And, you know, unfortunately what happens is patients go into the hospital as a COPD admit or a CHF, and they're walking and they're talking, but they do have a skilled need. And they end up are the ones that go home, and that is not identified within the hospital because, you know, typically that's not what you think of for home health agency. So these patients, only 31% of them had a home health agency at time of discharge. So this was one of the new tools that we created out of our gap of the medication management. We go beyond really of reconciling medications. When we go in, we measure them to what we feel is best practices. And we ran this tool across several pulmonologists in our area. And basically, it's a matrix that we score the patients based on, are they getting a short-acting bronchodilator, a long-acting bronchodilator, a steroid. So the drug categories are on the left, and then we look at can the patient actually do the technique? Do they understand how the technique works? Do they also know what it's for? And then we score them based on that. And if they come in substandard or that we need to review their medications, we actually go back with the physician and ask for an order. And you know, sometimes you feel like you're treading on water, and you think that you can't go to the physician and ask, oh, maybe you missed a medication. We've had great success with that going back, because a lot of times the hospitalists are involved. They don't know what the patient's on. As Becky said, they're on something different within the hospital. So this really allowed us to really look to see what the patient was on and what the best practice was. We also developed a lot of easy to understand training tools to go with this program. We have the actual, we use the American College of Chest Physicians Living Well with COPD. It has great pictures in it and has really been a good tool to use for patients. Not a lot of words, more pictures. We also created something on what to do in a flare-up, something very basic, but we have them put it on their refrigerator. And this was something that came out of the lack of introduction or ordering pulmonary rehab. And we found that patients, when you're trying to explain to them pulmonary rehab and you're handing them a brochure of treadmills and exercise bicycles, and they look at that and they say, I just was in the hospital for 4 days. The last thing I want to do is get on a treadmill or get on a bicycle. So we actually introduced them to pulmonary rehab as a COPD independence program. It is a way to build confidence, the way to understand how to become independent again, and really give you a bounce back and camaraderie to that. So this was really key in trying to get our pulmonary rehab numbers up to our referrals. So another key component is we can't just think of the hospital. We can't just think of the home care company. You really need to implement a high-performance network. It's not all going to happen on the hospital end. It's not all going to happen on the home care end. We all need to work together. So you really need to create a network around your program, and that includes your referrals. We've got a lot of hospitalists involved in our program, pulmonary specialists. Case management has to have the buy-in as well as your primary practices. You have to look at the subacute level, the LTAC or short stay visits possibly, the skilled nursing facilities. And we're finding that a lot of our readmissions are happening because they're being discharged to us from a skilled nursing facility, and then they're going right back into the hospital because they're discharging us right when their days are almost up. They're giving them to us, and then they're going right back into the hospital. So what we're trying to explain to these skilled nursing facilities is they are going to be held accountable as well in the future. Or hospitals are just not going to align to them, because if they're going to the subacute facility, then they may be readmitted. And we had a great example of this week. We had a pulmonary fibrosis patient, very severe end stage, was discharged to a skilled nursing facility that did not have any respiratory care practitioners on staff. So there was no respiratory support in that skilled nursing facility at all, and when his saturations dropped, they'd bump him up to 10 and shipped him back to the hospital. So we've got to hold everybody accountable for that care of that patient. And of course, on my end with the home, really need to look at respiratory services, hybrid HHA, or line up with an HHA if you're a DME company. Really look at sleep lab and screening, and align with rehab and OT and PT as well. Then there's a lot of ancillary, the telemonitoring field, look into nutrition management, secretion management, and some of the new ambulatory ventilation that's out there. So really, to sum up everything, what we have to think of is the future of healthcare is beyond a single site. It has to be patient-centered versus task-centered. We have to think of the patient. We have to partner with hospitals to address rehospitalization. And we all have to reconnect the physicians into that continuum of care. And we find in this area that that is a big missing link. They're so busy. The hospitalists are taking care of the patient. The PCPs and the pulmonologists are not pulled into the mix. So we need to reconnect all the physicians. And outpatient services are really linked to that home care data. You have to be able to implement higher technology therapies, increase or link databases and point of care so that you can measure your outcomes to support what you're doing. And with that, I will end my portion and take it back to Bill.
Thank you very much. That was a terrific presentation. I will express my appreciation to all of you. We have very few minutes left, but I do want to redirect this back to Greg's opening statement because that really lays the foundation for why this is so important. These penalties for readmissions are real. And in addition, in 2015, COPD will be one of those readmission criteria. So it's now time for everyone to get their programs geared up to reduce readmissions. And in doing so, you can certainly demonstrate your value to your employer because you're going to save that person money. Let me look at the questions real quick, and I'm going to start back here at the beginning. Let's see. Greg, let me call you back again. One of the persons was asking about the percent adjustment factor. Will the percent adjustment factor be applied at the end of the fiscal year and a cumulative amount to be repaid by the health care facility to CMS? In other words, they're asking, is the money something that the hospital or the provider is going to have to give CMS, or is this going to be withheld from future payments? Oh, gosh. Can you hear me? Testing, testing. Oh.
I hear you, Bill. I was just can't hear Greg.
Oh. Okay. Okay, well.
Bill, this is Becky. I'm on the line, and I have the answer for that. The entire amount will be withheld up front, and you have to earn it back.
Okay, great, great. Well, let's see here. There's another question here. Becky, there's a couple that came up in your area, too. Let me just quickly go look at that. How do you make sure that communication is shared between your therapists and the other staff? Is there anything special that the exact question is, how do you keep messaging shared with the patient between PT, CS, and floor RT consistent? Is there any special emphasis there?
There is. The communication between our clinical specialists and the staff RT is a priority, obviously. The clinical specialists at this time work Monday through Friday, and on Monday when they come back they have a lot of catch-up work to do, but almost every day on every patient that we are treating for COPD exacerbation, there is communication between the clinical specialist and the staff therapist. In addition, the clinical specialist documents in the electronic medical record exactly the discussions between the patient, what the plan is, so that the therapists are able to go in, and the nurses and the case managers and the physicians go in and see what has been discussed with the patient.
Okay. One last question. Do you folks see any new technologies that may have a positive impact on frequency and severity of exacerbations in COPD?
I can answer that one.
Okay.
We've been doing a lot of work with Breathe Technologies and the NIOV system. It's a 1-pound portable ventilator, And we have done a study that will be presented at CHEST, actually in Atlanta, and I'm presenting a case study at AARC Congress. But we have we tested 30 patients with COPD that were unable to complete 4 ADLs, and they had a Borg score of greater than 3. And we tried them on their current oxygen system. We had them do ADL activities of their choice. We then repeated the same thing on the NIOV system, and in every case they were able to exercise and perform more ADLs and last longer. Their endurance increased. The case study that I'm presenting is really an individual that completely, it brought his life back. And he has pretty much told me that this has given him his life again, and he feels like his lungs did when he was 30. So I think there's some hope out there. I know they're working at getting reimbursement for this. Right now there's not a code for it, but it is definitely something that is out on the radar as far as new technology.
Well, thank you very much. Again, I thank all of you for your wonderful presentation today, and I want to remind all of you that every member who wants to earn CRCE for their participation day must complete the evaluation at the end of today's program. And if you're watching this as a live, if you're watching this as an archive. Hang on a second. If you're watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRCE contact hour. If you're watching this as an archive, this does conclude our presentation. To complete the evaluation and obtain your CRCE contact